Good evening, ladies and gentlemen. Let me first thank Amida for inviting me, and I think it's an important topic that you understand few things beyond eye. I have no conflict of interest on this topic, but I have been a part of the multi-center trials in most of these medications, diabetes medications like SGLT2 inhibitors and DPP4 inhibitors. But I'm going to mention their names here, but I have no conflict of interest. Ladies and gentlemen, key components that I'm going to discuss here is something about diabetes, but I think it may be important for all of you, and a bit of thyroid disease, and then pituitary tumors a bit, and calcium-related disorders, lipids, and sick day rules in steroids. Now, ladies and gentlemen, if I just put this slide on, I think you will understand that diabetes has huge diabetes-related retinopathy. But I'm not going to talk about retinopathy at all here. But whatever the disease you have, which can cause vision problems, if the patient has background diabetes, it's extremely important that you get the best control, because unless you're going to have a problem in future. If you look at the diabetic retinopathy, actually the prevalence is with actually when the patient has more duration of diabetes, longer duration of diabetes, you have more chances of getting retinopathy, as well as the glycemic control. Those are the two most important factors in retinopathy, and also other risk factors are like hypertension, dyslipidemia, and diabetic nephropathy. If you see them, I think looking at the eye is very, very important, and to understand whether the patient has this retinopathy. And if you look at the leading cause of blindness in a working age group is diabetes. I think that is important to understand. The working age group is diabetes. Now, you look at many types of diabetic retinopathy here, but what is more important here is you look at the retina and you send the patient home, patient will end up with blindness, although you actually do the correct thing. But the problem is that we need to balance this stuff and see whether you are going to do something to deteriorate or progression to be reduced in diabetic retinopathy. How you do that? Optimize the medical conditions. Even if you treat the diabetic retinopathy, you have to maximize your medical treatment. If you can't do that, you have to get some physician to do that for yourself. What are the important factors? The blood sugar control should be HbA1c should be 7 or less than 7 in order to reduce the progression of the retinopathy or to stop the onset of retinopathy. And other important thing is the blood pressure should be 130/80 in majority of the patients if you want to reduce the progression. I think if you look at diabetic patients, their blood sugars are controlled, but blood pressure is never controlled. People are not looking at that at all. But if you look at the blood pressure and blood sugars together, more important thing is blood pressure, not the blood sugar. Therefore, you have to look into this point. And also the lipid control is extremely important. LDL cholesterol should be less than 100 or less than 70 in patients who are having cardiac disease, in patients who are having diabetes. So lifestyle modification for everybody. Try to at least try and maintain the weight if you can't reduce the weight. We know that weight is one directional. That is the most important thing to understand. You can't just reduce weight the way you want. It is subcortical as well as it's one directional. So when you see a patient who is obese, try and maintain the weight, whatever the weight you are dealing with. And then just to see whether the patient is on an ACE inhibitor or ARB blocker, and an aspirin if the patient has established cardiovascular disease or high risk of cardiovascular. These things should be there when the patient leaves the ophthalmology clinic in order to reduce the progression of the disease. Now, screening is type 1 diabetes. After 5 years of onset, you start screening. In type 2 diabetes, at the time of the diagnosis, you have to screen the eye. And if the actual eye is completely normal, you can go for every other year looking at the eye. If there's any kind of retinopathy, more frequent checking is important. Now, if you look at why diabetes is important in ophthalmology, if you operate on a patient who has got poor glycemic control, you will understand that you're going to have more complications with infections. Higher the HbA1c, higher the chance of getting infections. After whatever the procedure you do, even the cataract, if you do in a poor glycemic control, you're exposing yourself into getting into an infection. So get the best blood sugar control prior to whatever the procedure you do. But the important thing is you should never ever admit a patient to a hospital to get the blood sugar control. It should be outpatient, not inpatient. Now, a few things about diabetes here. There are few adjustments you need to do if the patient is going for minor procedure or a major procedure. If the patient is going on a local anesthesia, nothing is necessary because there is no fasting is important here. But if there is a minor procedure, metformin and a SGLT2 inhibitor should be stopped about 24 hours before. And a major procedure involving general anesthesia, these things should be stopped about 2 to 3 days prior to surgery. Why SGLT2 inhibitor is very, very important for you to stop it? Because when you are on a SGLT2 inhibitor, you are always like 12 hours fasting. If you get more fasting, you are going to get into a normoglycemic acidosis or ketoacidosis, which can kill the patient without your knowledge. At the same time, if the blood sugars, the control is like 140 to 180 inward, if you can maintain that with whatever the medications you use, I think you are safer in patients with diabetes or any other procedure. So if a patient is on type 1 diabetes, if you keep fasting, you must understand that there should be a long-acting insulin should be around. If you are going to be fasting on type 1 diabetes without a basal insulin, you have put the patient into a ketoacidosis. That is for sure, even the patient is having normal blood sugars. Therefore, type 1 diabetes, basal insulin should be there to make sure, because there is a patient is getting gluconeogenesis. Now, hypoglycemia is very important. Make sure that in the ward, whatever the reason, don't make a single hypoglycemic episode in a patient, because it increases the cardiovascular risk, it increases the arrhythmias and death. And if you get a one hypoglycemic episode, you are going to have a lifelong poor control because of that experience. I'm sure you have not experienced this. And if you experience it, you will never get a good control in lifetime. And I have just put it here because of the SGLT2 inhibitors are so commonly used. You have to be careful because they can die without your knowledge. But good thing is that nobody knows the reason of death, because patient has normal glucose and dying without anything. But we all should understand that we can prevent this. Even in Oxford Center, the commonest cause of death in patients who are having diabetes is a euglycemic ketoacidosis without their knowledge. That is for diabetes. If you have any questions, I'm happy to answer. Thyroid eye disease, I thought it's an important point to understand. It's a Graves' ophthalmopathy I'm going to talk about to you. And it's an autoimmune disease, and the commonest, mainly it's the commonest extrathyroidal manifestation. And 90% is usually hyperthyroid. At the same time, 10 to 15% can be euthyroid or even hypothyroid when they present to you. So if you look at the eye, sometimes maybe completely thyroid functions, this can be normal, but still having Graves' eye disease. Now we know that's more common in females, but when the males get it, they have a severe eye disease and may need more treatment. And also 20% of patients with Graves' disease only get eye disease. The majority won't. That's an important point to understand. So majority will have no problem with eye disease, only 20% will get eye disease. And majority of that, 2/3 of the patients who get the eye disease are mild eye disease. But 1/3, which can give rise to a severe eye disease, needs your input as well as our input together. Now, if you look at the pathogenesis, actually, it's important that it's an autoimmune disease, and actually there are two receptors are involved, TSH receptor in the eye as well as IGF-1 receptor in the eye. Both these receptors are involved in this particular disease. And if you look at these two receptors here, TSH receptor is there in the eye, and also IGF-1 receptor is there. The antibodies comes and bind, then hold the process of inflammation will start in the eye, and there can be fibroblast and other things will start accumulating there. If you look at the clinical manifestation, the bilateral symmetrical disease is the majority. Therefore, you will not have any problem if you are seeing bilateral disease, unlikely that you are looking at retrobulbar problems. But sometimes can be asymmetrical, 5 to 15%, sometimes can be unilateral, that you may have a problem because you may think that there is some retrobulbar issue. So these are the clinical manifestations. All of you know that the common manifestations, that I need not to go ahead with this, but when you have this, I think it's important that you look at this and diagnose the Graves' ophthalmopathy, and if it is mild and moderate disease, to refer to a physician, unless that they can get more and more problems. Now, more importantly for you guys, it is important to diagnose the dysthyroid optic neuropathy or sight-threatening eye disease. If you miss that, the major problem. So, reduced visual acuity in a patient who has got Graves' disease or loss of color vision or visual field defects or blurring of vision, actually that suggests that the patient has got, sight-threatening eye disease, needs urgent care. These are the risk factors. If you see these patients, you have to always look at whether they are smoking and ask them to stop smoking, and look at their thyroid function test not to cause hypothyroid because they can get worsening of the eye disease. And also it is important that you should not give radioiodine moderate to mild to only mild disease you give radioiodine, moderate to severe you have to be careful. And also cholesterol has a role here. If you have a high cholesterol, try and start with atorvastatin and reduce cholesterol, that reduce the eye disease risk. Now, clinical assessment even in your clinic is important to see whether this patient has an active disease or an inactive disease, because if there's active disease we treat, if there's inactive disease we don't treat. And then you have to understand whether this patient has the severity, mild, moderate, severe. When you define whether the patient has mild, moderate, or severe, that actually decide what kind of treatment that you start on this patient. That decide on the severity of the disease. So this is how you look at the disease activity, and I'm sure that you know this. And if it is more than 3, the patient has active disease. And the severity is very, very important for you to understand. Severe sight-threatening eye disease to be understand, because this patient needs urgent care. Now, imaging for a thyroid eye disease is actually exclusion of other diseases are important. When the patient is euthyroid having eye disease, you need to be looking into this. And also clinically unilateral disease, you may have to image this. When there's absent upper lid retraction, which is very specific for Graves' disease, if it is not there, you need to be imaging. And also when have atypical signs, then we need to go ahead and do the imaging of this way. The management, very, very quickly, there is management is huge, medical management, radiotherapy, and surgical management. Just want to show you that if you diagnose the patient who is not having severe sight-threatening eye disease, patient still needs certain treatment options. And these are IV methylprednisolone, which actually be given in some other eye clinics as well, so you should better know this a bit. 0.5 milligrams of methylprednisolone weekly for 6 weeks, and if there is a partial response, you give a half a dose for 6 weeks, and there's high dose as well for about 6 weeks. So these patients need a physician referral to start this medication. Now, when the patient has second-line medications like intravenous methylprednisolone high doses, and oral prednisolone alone has almost no place. That's what I want to show you here. There's another medication, now orbital radiotherapy, and there are newer medications which are not available for us, have a huge benefit in thyroid eye disease at the moment. Now, sight-threatening eye disease, if you see immediately, you need the patient to be high doses of IV methylprednisolone. That's a 0.5 to 1 milligram daily for 3 days, and look at how the patient behaves. And if the patient is not improving his vision, needs a decompression at this point. Before going into the thyroid, any of the eye surgeries, thyroid dysfunction can cause problems, but minor surgery, no issues. But if the patient has thyroid disease, if the TSH and free T4 is normal, you are in a better wicket. But if the patient's urgent surgery, free T4 need to be normal without looking at the TSH. If a patient has thyrotoxicosis, and if you go ahead and do a major surgery, patient can end up in a thyrotoxic crisis, which can endanger the life. And we have seen patients dying with this disease when you are not careful. If the patient has hypothyroidism, severe hypothyroidism, they can go into hypothyroid crisis after surgery if you are not careful. Just few words about hyponatremia, which is important, right? If the sodium is more than 130, you can go for minor or major surgery without any problem. But the problem starts when the patient has low sodium. You start correcting them with a 3%, but that is very, very careful, because the correction should be less than 8 millimoles per 24 hours. If you do more than that, you are getting into a real trouble, because you are getting into the osmotic demyelination syndrome, which is an irreversible damage to the brain, and patient will have no quality of life after that. So just I want to show that when you correct sodium, be careful, get a physician's input in that. Pituitary tumors, all of you know that majority of the pituitary tumors are referred by the eye surgeons to us because of the visual field defects, sometimes visual acuity issues. Sudden visual loss is very, very important in apoplexy because majority of the apoplexy now we are treating medically. Sometimes if there is a major problems, we go ahead with the emergency surgery in the pituitary emergency surgery. I think those things, if you see them, please look at the patient may need certain investigation to see whether the patient has a pituitary tumor. Ophthalmic manifestations of hyperparathyroidism means important if you have band keratopathy, conjunctival calcification, calcification of the eyelids, uveitis, just do a serum calcium is important. You may diagnose this condition. We have seen few eye surgeons are sending these patients to us. Then hypocalcemia, posterior subcapsular cataracts, so you probably will diagnose this. Ophthalmic manifestations of lipid disorders are common. They are not very specific, but still it's important fact if you see that patient may need a lipid profile. This actually I got it from BMJ, British Medical Journal, a few years ago. A patient, obese child, was referred to eye surgeon to look at the eyes because of the deterioration of the vision. Eye surgeon says that there is a retinitis pigmentosa, and then eye surgeon says, please look for extra digit in the hands. So eye surgeon is not happy to look at the hand. So this is the problem of specialties. I think he knows the diagnosis, that's why he write like that. So look at a extra digit because he knows the diagnosis is this, but unfortunately he only wants to look at the eye, but not beyond the eye. So I think we should also avoid that. And these are some other conditions which can give rise to, eye and hormones together, especially when you see optic atrophy. The conditions like Kallman syndromes are important, and all of these conditions need to be keep in your mind when you look at your eyes. Sick day rules are important, I thought, because majority of our pituitary patients are on steroids and come to you for surgeries. You sometimes just don't know what to do, and if you're doing a minor surgery, you could just double the dose, go ahead for 48 hours and go into the normal dose. If you're going for major surgery with a general anesthesia, start with IV steroids of 100 milligrams of IV hydrocortisone, go for about 48 hours, then come to the normal doses, and then double the oral dose and come into the normal doses. So I think it's important that all of you know that, and there are a majority of our patients are there. So take home messages, ladies and gentlemen, diabetic control is important in all aspects to avoid complications of eye problems. I think thyroid eye disease is poorly managed by both of us. I think not only the endocrinologist or physician, but both of us are not doing properly, and I think we have to improve that. Hyponatremia is a disease, the condition where sometimes you can get into a trouble, and pituitary disease, actually most of the times you refer the pituitary conditions to us. Calcium disorders, we have diagnosed few before because you have referred to us, and also sick day rules and steroids are important in managing these issues. Thank you very much.